Okay, great. So this patient was a 45-year-old athlete. So he played weekday, weekend rec basketball. Father of 2 boys, very active with his kids. He had a brostrum done 4 years previously because of recurrent instability. And now he's still having recurrent pain, instability, getting swelling. He still plays basketball with ASO. He doesn't want to give it up, but it's becoming more and more difficult for him. So this is what his shoes look like in the office. This is what his alignment looks like. He's unstable to draw and tilt. He's got an apprehension. He's got a hindfoot-driven varus malalignment. These are his x-rays. And an MRI, which showed medial tibial talar chondral wear with evidence of anterior impingement and synovitis. And you can see impingement lesions here. You can see slight varus. You can see not significant cavus. So really what to do. So 45-year-old active male, he's got recurrent instability following repair, increasing pain and limitations. So in your experience, what I guess I would ask the panel, Sam, would you do an injection on this guy? Is that the answer? Is it his cure to all his ailments? Okay. Would you just go? Would you want to go in and scope him, clean him up? Would that make him better?
So I probably wouldn't scope this.
Okay. Would you revise reconstruction?
I don't think this is a reconstruction problem.
Okay. So he's 45, right?
Right. He's 45.
He wants to get back. He
Right.
He doesn't want to be painful. He wants to do stuff with his kids.
I wouldn't scope him. I might clean up his joint, but it's probably something I would do open.
Would you do some kind of augmented repair? Tighten him up again?
So I kind of think you're going to get in there and you're going to, if I did scope him, I would be just to get a better look at his surface. But I got a feeling this guy's going to have a lot of chondral wear. And my concern is that you could do all that and not change anything. Now, I think you can get rid of his osteophytes. You could scope him, clean him up a little bit, but any way you do, you have to get rid of his osteophytes, right? And then I think he needs something bony to try to correct his ankle, because I think you're going to have chondral wear there.
So you would do an osteotomy?
I would do an osteotomy. Now, would I do a tibial osteotomy? I'm doing probably a calcaneal osteotomy. That's what I think might help him the most. Tibial osteotomies, now he doesn't have all that much deformity, so maybe a tibial osteotomy would help. They're a whole lot of difficult, for the patient and get it to heal. But I think maybe moving his heel over might be something that would work better for him given the amount of deformity. And you could check and see if he has any residual instability, but I don't think this is an instability problem. I think this is an arthritis problem.
Mark, would you agree with that? If you're considering a bony reconstruction, would you also go back? Would you do some kind of stem cells or put something in the joint if it's arthritic?
Yeah, so Craig, you're starting us off with an easy one, right? So yeah, this is a hard one, and this is like, I would agree that you can't, little procedures are really not going to address the long-term natural history of this. There's this whole classification of this, I think it's the Takakura classification for how much varus arthritis you have. And this is like a 3A, 3B, which means that even a supramalleolar osteotomy is probably not going to help it a ton. Like you're basically buying time potentially until you have to do like a more definitive procedure here. So I would argue you can do something for the alignment. The joint is already pretty shot, so unless you're going to get really aggressive and do some sort of like, allograft reconstruction or something, which may be a big hit for a 45-year-old. But I would argue that doing like a scope procedure or just shaving down the bone spurs is not going to alter kind of the natural history of this. So I would do a bigger procedure probably.
Mm-hmm. I mean, would you consider any kind of definitive like a fusion or ankle replacement depending on the
He's
wear?
45. I mean, it would be hard.
Right.
But I can just tell you, like doing just a supramalleolar osteotomy for this probably is not going to be that great either. This is what I mean. This is a tough one. Like I've done distraction for these, which hasn't worked super well. I've done distraction plus osteotomies. I don't want to put an ankle replacement in a 45-year-old. Fusion has its long-term. This is like one of the hardest operations to deal with, I think.
Right. And again, of course, managing the patient's expectations is critical, because this guy's going to want to go back to his rec league, he's want to play with his kids, so he's going to expect to get back. So this is when he scoped him. So definitely had wear. It was localized medially, so really no lateral wear. So debrided his osteophytes anteriorly, and this is what he's left with. I mean, if you're able to correct his alignment, I mean, is this something you would ever? What would you do for this? You don't want to do anything too big with allograft would you do stem cells at the same time?
Biocartilage, probably.
Biocartilage, yeah. So try and replace it. And then I slid his heel, and I did an osteotomy. So we'll see how he does. Now, Dr. Claire, when you're doing this, is there a certain order that you do your osteotomies? Does it matter? And I also revised his ligament reconstruction at the same time. So like, what would be your order of those things? So you do the scope first, and then let's say you have tibial osteotomy, you have calcaneal osteotomy, you have your ligament reconstruction. Like, is there a certain order that you like to do it in?
I think at least with the distal tibial osteotomies, it's one of those things where you never quite know how much you need until you get everything else set. So it's kind of like doing osteotomies in the as you go back to front. I think you want to go bottom to top. So do your scope stuff probably first, slide the heel, and then figure out how much you need as far as distal tibia to be able to dial it in exactly. And they're so powerful, it seems like they don't need as much as you think they might need. A couple millimeters might do it.
Would you agree, Dr. Jacobs?
Yeah, absolutely. My concern with this is that you look at your medial clear space and it's still, bone on bone. So you've improved the overall joint alignment. You've taken the pressure off it, and the goal with this would be to hope to, take enough pressure off it to, give him 5, 10, 15 more years,
Right.
Down the road. So I would agree.
And I discussed that with him as
Yeah.
well. Yeah. All right. Well, he's about 6 months out, and he's playing actually, so he's happy. But so we've had a lot of discussion as well about stem cells and stuff like that. So potentially buying time, then potentially going in and doing some type of cartilage replacement procedure to again buy him more time. But at least now his alignment's restored, so he's in neutral, which is good. So we'll hope for the best. Yeah, Dr. Brott.
Not criticism, but if you look at his lateral gutter, what we've learned a lot in total ankle is that it's really a rotational issue. We spend a ton of time. I spend way more time thinking rotation now than I did 5 years ago. And so his instability had a combination of rotation. And I'm not sure without getting a little more aggressive in that lateral gutter, if he was ever able to kind of spin back around. What do you think about getting more aggressive in that lateral gutter?
I think it's a great point. So when on my total ankles, I'm actually very aggressive with my gutter debridement. I haven't necessarily done that in these kind of things, but I think it's a valid point.
Yeah, I just think instability, we get obsessed with coronal, and I think instability has got a lot more rotation, and Mark brought that out in his talk, that medial instability or global instability is not a coronal phenomena, it's a rotational phenomena.
Yeah, I did go after, and I shaved the medial side, but I did not go after the lateral side.
How do you go about doing that without, when you know enough's enough?
Well, in this situation, he's going lateral anyways, and so I would probably completely destabilize this ankle before I ever started, and I would be pretty aggressive in my lateral takedown. And then I would just take your approach, and I'd start building him from bottom up, and I'd probably dial in the tibial osteotomy as my very last thing. Although I agree with whoever said that once you start doing tibial osteotomies, you're in for it all, because those ones bite you back frequently. So I'm impressed you got it to heal so quick.
All right, can you pull up the perineal case now, Bridget? Okay, so this patient, 51-year-old male runner, doesn't recall any specific injury, but he started getting pain and swelling. He feels weak. He has difficulties with uneven ground. The ankle kind of rolls on him. He failed bracing and physical therapy. MRI showed a full thickness tear, the peroneus brevis at the level of distal fibular metaphysis with retraction. A lot of synovitis. The peroneus longus is intact. So this is the MRI. So Sam, what do you think about this? What are his options here? Would you inject him with stem cells?
So, you know,
That's not
no,
gonna do it?
No.
All right. Because they saw the physiatrist and that was recommended to them, so.
Right.
Okay, you're saying no.
And they recommended they get their credit card first, right?
Would you offer this person an ankle fusion?
No.
All right. How about tenodesis? Would you?
Well, that's what I'm thinking is tenodesis, but, you know, I'd have to look at it when I get in there. Because, you know, the MRI,
So full retraction,
Yeah.
4.5 centimeters.
so I think you're probably going to have to do more than a tenodesis, and I think you have an option of doing an FHL tendon transfer, and you probably could use an allograft. Like I said, I haven't used many allografts. There's not a whole lot of studies on allografts. There's not a whole lot of studies on FHL tendon transfers, but there's more on FHL tendon transfers than there is on allografts. So I would probably, in this case, consider doing a tendon transfer.
Mhm. Would you do that in one stage or two stage? How do you make that decision?
I decide I'm doing it in one stage. So I don't do two stages.
All right. So if you get in there and that the bed where the tendons are is really just fibrotic and the longest is even scarred down, would you ever give it consideration
I
doing
mean,
two
to
stage?
do it, no.
Putting hunter rod in there?
No.
Okay.
Yeah, I mean, I think there's more literature. That shows that, you know, you can do these in one stage, and I think you just need to clean everything out. Doing an FHL is not really a difficult operation at all, and, you know, the ones I've done have worked pretty well. Matter of
great.
fact, they send me other friends to have the same operation who really don't need it. That's not what their problem is. So I've actually been pretty happy with that operation. But they've been on patients, you know, who have these degenerative tendons. They're bad for a long time. It bothers them, so they feel a whole lot better just getting the degenerative tendons out of there. Now, you know, are they as strong? No, but they weren't that strong in the first place because those tendons are all a mess. They don't work that well anyway.
Yeah, I would agree. I mean, that's going to be pain relief by itself. I've had a couple cases where both tendons were chronically torn, chronically retracted, and that bed was completely fibrotic. So this case I actually did in two stages. So I actually did the hunter rod, I put it in there, came back 3 months later, and it's amazing. It just recreates the synovial kind of membrane there, and it's allowed an easy transfer, nice mobility right away. For the most part, we want to go to one stage for us or for the patients. So anyways, this was the injury. So you can see the longus is intact, the stumps of brevis are there, and there's no way we're going to repair this end to end. And so I've done more doing the allograft. So I use Emiteno saying that you could do autograft as well, but similar deal here that you do. I just imbricate it distally, usually with pulver-calf weave. As long as you have a distal stump, if not, you have to put an anchor in base of the fifth metatarsal, and you can build off of that. Then you want to shave the correct tension. So usually I just have the foot neutral dorsiflexion, no inversion, eversion, and I pull approximately, make a good accursion of proximal stump, and I feed that up a little bit. And then usually at the 5th% mark is where I want that to be fixed. So then I'll do the pulver-calf weave approximately as well. And here you can see on the left, you know, it's nicely reduced, and the tendons are checking well, and then is the repair. So, and he went back to running, you know, in probably 7-8 months.